Hello, everyone. My name is Nick Smith. I'm currently a fourth-year cardiology and critical care medicine fellow, and I'm chief fellow at the Johns Hopkins Hospital. We're so excited for this collaboration between CardioNerds and SCAI Shock 22 with mentorship from Dr. Truesdell. And I'll let Gerline introduce herself.
Hi, everyone. My name is Gerline Kaur. I'm a second-year internal medicine resident at Brigham and Women's Hospital, and I'm so excited to have Dr. Bill O'Neill here with us today. I'm also part of the CardioNerds Academy and director of the CardioNerds internship. So I'll start off by introducing Dr. Bill O'Neill. Dr. Bill O'Neill is an interventional cardiologist and medical director for the Center of Structural Heart Disease at Henry Ford Hospital in Detroit. He has been at the forefront of many major advancements in interventional cardiology and is a national leader in cardiogenic shock by virtue of launching the National Cardiogenic Shock Initiative in 2016. Welcome, Dr. O'Neill.
Thanks very much, Gerline and Nick. It's great to be with both of you.
So RECOVER-4 is a very anticipated trial that will assess whether Impella pre-PCI is superior to PCI without Impella in patients with acute MI cardiogenic shock. So Dr. O'Neill, when I first heard of this concept, it seemed radical, which is not unusual for landmark analyses. There's shock and awe, no pun intended, simply because of the novelty. Can you talk a little bit about how we got to this point where we're randomizing a patient with a completely occluded coronary artery in cardiogenic shock to get Impella pre-PCI versus opening the vessel immediately?
Yeah, just very briefly, I've been involved with acute MI cardiogenic shock since January of 1983. That was the first time a patient presented to me in a cath lab. We'd started an angioplasty protocol for acute MI therapy in December of 1982. And a month later, this patient came in from the emergency room, blood pressure 70, cold, cyanotic, peripherally vasoconstricted, huge anterior SCAI elevation with axial elevation in 2-3 and AVF as well. And we were barely able to palpate a pulse. We got a axis, and then we shot an angiogram, and his LAD was occluded. At that time, he was on leave-of-bed with a blood pressure of 70. And we put a wire across the LAD, across occlusion, and that opened up the vessel, and also to collateralize flow to the distal right. And immediately his blood pressure went from 70 to 110. And it was like my eyes lit up. I thought, holy crap, this is absolutely amazing. And that was the first patient I treated. And within that, I realized that if you could do this on a regular basis, you would improve the survival. Remember, before we started doing any of this, there was a 90% mortality for these patients, and there still is a very large mortality. So we published our first work in Circulation in 1987, and at that time we found that angioplasty improved the survival to 50%, and it's remained at 50% for 30 years. And so that's been kind of the struggle and frustration, but we haven't really changed very much. We take the patients to the cath lab, we identify the culprit, we open up the vessel, whether it's with a balloon or with a stent, you still open up the artery. But the frustrating thing has been that about half of the time the patients just sort of dwindle, and their death is really very morbid. They'll have persistent ischemic dysfunction, and then something will break. Their liver will go, their kidneys will go, their bowel will go, their brain. So some other thing is ultimately was going to cause them to die. And that's really been the frustrating part. Half of the patients do really well. And the problem is, how do you improve that outcome? And so in 2007, the FDA approved Abumed for use in mechanical circulatory support. There wasn't a disease indication. It was just if a doctor thought a patient needed support, just like with balloon pump, and they offered that support. And so people started using Impella, but there was no protocol. So between 2007 and 2016, about 16,000 patients in the US were treated with acute MI shock with Impella, and the survival was 50%. So we weren't really doing any better. And at that point, we said, wait a minute, we've got to figure this out. And the device definitely provides better power and better support. But if you don't organize and protocolize this, you're not going to be able to improve outcomes. And so we did that in the National Cardiogenic Shock Initiative, which started in 2016. We enrolled 406 patients, and we were able to improve the survival to 70%. And that's by a systematic protocol, early identification of the patient, putting the Impella in rapidly, putting the Impella in before you do the PCI, and then using hemodynamic measures to try to figure out whether or not the patients are out of shock or not. And that program really has resulted in improved outcome. I know that all the nerds out there are saying, wait a minute, there's no RCT. And you're absolutely right, there is no RCT. But you can't do an RCT until you know you got the therapy right. So for 5 years, we try to figure what is the program, what is the therapy to optimize care. And I think that that has matured to the point now where it can be tested. And that's really where Recover 4 comes in, because we're using optimal Impella Swan guided support and then doing usual care. And usual care is whatever the institution is usually doing, not using Impella. And unfortunately, it has to be done, because without it, there's always going to be continued argument with people saying, well, you guys, there's no randomized trial. You guys really don't know what you're doing. You're cherry picking, whatever. But until we get this, there won't be a peace in the realm.
That's great. That it's so nice to hear the entire arc of where we were and where we are now, and actually how little progress has been made even over the course of some of your career in some respects, but in others, major leaps. So I guess my next question will be that a lot of us have learned and been really excited about the door to unload, the DTU trial, which is Impella 30 minutes pre-PCI. I was wondering if you could talk a little bit about, that trial, the overlap, and what makes this trial, a little bit different.
Well, yeah, so if you take a look just broadly at PCI for STEMI, we are routinely getting, if a patient comes into hospital that's not in shock, you should anticipate a mortality less than 2%, in-hospital mortality less than 2%. And so we've done an incredible job of systematizing across the country. If you're in Boston or in Baltimore or Detroit, wherever, you come into a hospital with a STEMI and you're not in shock, in a STEMI capable, PCI capable facility, you'll get pretty much exactly the same care with very good outcomes. So that whole therapy has matured, and it's been an incredible testament to the advances of acute MI care. But we're not totally there in terms of the long-term outcome. We know that hospital survival is extremely high, but now we want to try to take a look at the trajectory. And the patients where we're not doing as great a job are patients that are coming in sort of after 2 to 3 hours with anterior MI. And in those patients, we open up the artery, they survive, but they have a very poor ejection fraction with an anterior wall that is basically severely damaged. And then that's going to kind of give the trajectory of care for the patients over for the rest of their lives. So we've been looking for ways of decreasing infarct size, really, again, for the last 30 years. And the best thing you can do is open the artery early. So early opening within an hour or two of onset of symptoms is absolutely the best therapy. But a lot of patients are coming in later, and those are the patients that we're trying to treat right now. So this is what the door to unload trial is patients coming in with an anterior MI that are presenting between 1 and 5 hours after symptom onset. So they're not the hyper acute, but they're a little bit later in duration. And we're taking the patients and putting the Impella in. And we were really concerned that people just weren't going to be able to sit there. Imagine you got a patient with a big infarct and they're writhing in chest pain and you're waiting for half an hour. We thought that patients were going to break the blind. So we did a pilot trial, and the pilot actually showed that we could do it, the operators. And what happened is that when the Impella was placed, the chest pain started to go away and the STs actually started to come down. And so the patients actually became quite stable. And the artery was able to be open in half an hour. And it was a 50-patient pilot that was published in Circulation. There was no safety problem, and the patients tolerated it. And there was actually a trend towards a decrease in infarct size, is what we're looking for. Dr. Naveen Kapoor from Tufts and Dr. Bart Maines from Europe have both demonstrated that if you unload the ventricle you actually decrease infarct size in an animal model. Now we're trying to demonstrate it in humans. And there are 50 centers around the country that have recruited, as of today, 200 patients out of a planned over 400. So we're actually rapidly recruiting, and I think within about a year or a year and a half, we'll have an answer. And that really could change the whole paradigm for care of anterior MI. Now, we've piggybacked a little bit of that onto the Recover 4 trial because we're kind of assuming that study is going to be positive. And so we're putting in the Impella before the PCI. We're not waiting it usually takes about 10 or 15 minutes to get the artery open after the Impella is placed, but we think that there is going to be some benefit. And obviously, if the DTU trial becomes positive, we would modify the trial in the Recover trial to wait for an obligatory half an hour before you open up the artery. But we're not there with Recover yet because of science. But I mean, I think I've been working on infarct size reduction trials for almost 20 years. We started using Percusurge, which is a thrombectomy device, to see if that would work. We tried balloon pump in the early 90s, and pexiluzumab, adenosine, cooling. The only thing that's worked besides the only thing that's actually been pretty systematically studied is supersaturated oxygen with Therox, and that does decrease infarct size, and that is FDA approved. That's the only thing that decreases infarct size. So we're hoping that putting in the Impella will decrease infarct size further.
Yeah, thank you for explaining how the Recover 4 trial kind of fits into the larger perspective of other trials like DTU. And I know earlier you mentioned that some of the work for Recover 4 came from the NCSI study. And for the NCSI study, institutions were told to adopt NCI's algorithm, which introduced a protocolized way to ensure timely recognition of shock as well as the utilization of early MCS. So what are some of the challenges that you've noticed in institutions adopting the algorithm, and how do you think that will affect the Recover 4 trial that's going to use the NCSI algorithm in the treatment arm?
Well, initially it was, as you guys said, it was kind of radical to try to get this done so quickly and identify these patients and get them to the cath lab. What's happened in the US is that operators actually were using the Impella kind of as a last resort. So the patient comes into the hospital in shock, they get the PCI, maybe with a balloon pump, and then a few hours later, they're still in persistent shock, and then they will escalate to try to put an Impella in. And we realized when we looked at the registry numbers that the longer you delay, the worse the outcome in terms of institution of mechanical circulatory support. And again, remember what's happening to these patients is as they remain in persistent shock for 6 to 12 hours, there's a lot of end organ damage that's going on. You get renal dysfunction, you get bowel ischemia, and ultimately you end up with something called SIRS, systemic inflammatory response. So the periphery is so vasoconstricted with high doses of alpha agonist that the tissue integrity really goes away. And so if they survive the initial phase, then they go into this sort of high output state where the SVR really drops, and there's nothing you can do. It's really kind of a refractory shock. And so the way to prevent this is to try to get the patients out of shock as soon as possible, to get them supported so that they don't wind up with those secondary complications. And I think that's really what we really try to do with this. In terms of the obstacles, again, I think is inertia, no randomized trial. People actually like it because when they start instituting it, they see a dramatic improvement in outcome. The best testament is from Inova Fairfax. I went and talked with them about this program, and I said, just look at your outcomes. And they looked at the 2 years before, and they had a 40% survival. And then they instituted the program, and then within a year, they published an 80% survival. So they doubled the survival within a year. And I think that's really the excitement that we're generating. I think it's really important to look at your outcomes. And if you're doing okay, then maybe you don't need to change things. But the problem with shock is that it's a complete morass right now around the country. If you go around the country, hospital to hospital, operator to operator, day or night, there's a complete difference in the way the same patient is treated. Like I said with STEMI, you're going to get exactly the same care around the country. With shock is entirely different. You may not get anything. You may get a PCI. You may get PCI in a balloon pump. If you're in an outlying hospital, you might get thrombolytic therapy. You might get ECMO support. There's a lot of interest in that. So it's honestly a morass, and we have to come up with something systematic. And I would say, if you think that this doesn't work, then define what your outcomes are at your institution. If you're getting a 50% survival, you're doing pretty much what everybody else is. If you're getting worse or better, then you have to, certainly if you're getting worse outcomes. And in the Abumet experience, there were centers that were getting 0 survival with use of Impella and shock. So something is really wrong if you're not getting anybody to survive an acute MI shock. And I think you really have to take a cold look in the mirror. What are you doing wrong or incorrectly, and improve your outcomes? Because centers around the country and in Japan now are demonstrating a greater than 70% survival.
So interesting. So pivoting a little bit, we know based on work from the cardiogenic shock working group and multiple studies you've co-authored, that isolated or concomitant right-sided congestion and failure is not uncommon in AMI and portends a worse prognosis. But, obviously we know an Impella is a left-sided pump. And, there's a delicate balance between selecting appropriate patients by phenotyping, taking the time and phenotyping them correctly, but then also, you want results that are generalizable and can be broadly applied to a broad set of patients. So could you talk a little bit about how Recover 4 will aim to balance these competing interests, and whether you'll be studying this kind of breakdown specifically, and just talk a little bit about the overall trial design in terms of patient population?
Well, thanks so much, Nick, for prompting me, because I think this is a message that I do want to get to your listeners. And that is that if you take a look at acute MI shock, 40% of the patients have some component of RV dysfunction or RV shock. And it's not just the inferior MIs. I mean, if you have a huge inferior infarct, then look out for RV infarction. But anterior MIs also have a component of RV dysfunction, because remember, the septum is part of what is actually generating force for the right ventricle. So if the septum is akinetic or dyskinetic, a big part of the RV is not working. And that can become quite a problem. So we've looked in the National Cardiogenic Shock Initiative, mortality for patients that had RV dysfunction was 10 percentage point higher. And it hasn't been really well recognized. We've been dealing so much with left-sided support that we're kind of not recognizing right ventricular dysfunction adequately. And so what happens is the right ventricle is not working, is not sending flow to the left side. The left ventricle is actually hypovolemic. And then the Impella is trying to pull, and you get chatter, and the Impella RP the Impella starts to go down in revolutions because you're getting too much wall suction. And so then, you're saying the device isn't working. That's not the problem. The problem is that you're not getting flow from the right to the left. So you have to recognize it. And there are right ventricular support devices that are available. And so it's really important to recognize that there is a substantial amount of right ventricular dysfunction, even in anterior MI. And so part of the Recover 4 protocol is to, after the PCI is done, we're going to be using the Swan-Ganz catheter for measuring hemodynamics. And that's really the only way. Well, you can do an echo, but quickly, hemodynamically, you can tell RV dysfunction. And if there is substantial RV dysfunction, then we're trying to use a low threshold for inserting right-sided support devices. There is the RP Impella that's available, that's actually now very easy to use, and will provide right-sided support, and that's part of the protocol. So we're not kind of competing, we're trying to integrate the whole thing to try to improve the survival. And it's really kind of interesting. This whole thing has kind of just dawned on a lot of us as we've been watching the left-sided support and keep hearing, oh my God, it didn't work, I put the patient on ECMO. And the reason that it didn't work was because the right side wasn't working. And ECMO is a very good RV support. You take blood out of the right side, oxygenate, putting into the left. So that does work for RV dysfunction. But you can probably do it with a little less morbidity with a biventricular support.
Yeah. Thank you.
Yeah, it's definitely very interesting thinking about the right ventricle. Just when I've been in the CCU as well, kind of sometimes we forget about the RV, but how important it is and how it affects what we determine about next steps for patients. And just to pivot off a little bit, I know you mentioned earlier that there's a lot of variability in practice when it comes to cardiogenic shock. And so far, there haven't been that many evidence-based treatments for acute MI cardiogenic shock because of the limitations of trials. They've been difficult to conduct, or they've been underpowered or neutral. So Recover 4 is definitely a very eagerly awaited randomized controlled trial in this area. So when do you anticipate the trial will start enrolling and see completion? And do you have any predictions of what the trial will show us?
I stopped predicting. I did a study back in 1985 with Eric Topol he was a Hopkins resident, by the way, so he's a storied alumni of your institution. But we thought that angioplasty was going to work. We've done a lot of work with angioplasty, and then we said, well, if that's good, but there's a delay, so why don't we just give the patients lytics ahead of time and then do the angioplasty? The best of both worlds. You can open up the artery early. It's not open, you can open it. And that study was negative. And the Europeans did a study and the NIH did a study. So you take three of those together and it's like, holy crap, we're killing people with angioplasty. So it just sometimes stuff that seems intuitively obvious isn't. So I've given up predicting. I'm hoping that we've improved it, because if Recover 4 works, that means that we've advanced the field and we've improved survival. So that's kind of my optimistic hope. This trial has to be done. This is going to be the last mechanical support trial in cardiogenic shock that's done in the United States. One way or another, it has to be completed. It has to be completed, and it doesn't really matter what the answer is. To be truthful, we have to come up with a clean answer. It can't be blurred or smudgy, and so it's got to be adequately powered. One of the things that, and you mentioned. Gerline, a lack of randomized trial. There's really been only one randomized trial in shock that was completed in 1997 by Judith Hochman and in the United States. In Europe, it's different. They've had like 4 or 5 trials. And the reason is that in Europe, they're allowed to enroll patients without consent and then retrospectively go back and get consent. And so there is actually a process in the United States called exemption from informed consent. And that's part of what we're doing with this trial with Recover 4. We've worked with the FDA already. They're already approved this. So we have an approved trial, and we're just sort of coming to site selection and use this EFIC exemption from informed consent process to try to more rapidly enroll the patients. And so we're hoping that the study is going to start sometime early next year, and we're actually in the site selection process right now.
Amazing. Well, thank you so much for your generous time today. And this has been a fascinating discussion, listening to the way this has all come about. And we're just both very thankful.
Well, I look forward to hearing more from you guys and seeing you up on the podium. And you might be talking about RV shock or acute MI shock. So love to meet you both.
Likewise.
Thank you.